Hey guys, I'm going to be talking about benign vulvar dermatoses, and I apologize, Dr. McGraw, this is probably going to go over 3 minutes, but I picked the ones that I think are most likely to show up on your NBME and Step 2. All of these have very similar sounding names, so hopefully this is helpful in differentiating between them. The first one is lichen simplex chronicus, or LSC. This is a pretty common condition. About a third of your patients who present with vulvar complaints will be diagnosed with LSC. It is a non-scarring inflammatory condition, and it is often described as the itch that rashes as opposed to the rash that itches. So these patients are going to present with a very itchy vulva that's worse at night. They may have a history of childhood eczema, asthma, allergies. On physical exam, the vulva is going to be very erythematous, thickened, lichenified. It's often described as being bark-like because it's so thick. And then you may also see excoriations from all of the scratching. It's important to counsel these patients to avoid scented body washes, scented pads or panty liners, and also to maybe change their laundry detergent because LSC is often associated with a contact dermatitis. So eliminating those irritants can be very helpful. It's also important to eliminate or rule out conditions like yeast infections that may also be causing irritation. As far as treatment goes, you can use a oral antipyretic like Benadryl to help alleviate some of that itching at night. And then your mainstay treatment, which is true for all three of these conditions, will be topical corticosteroid ointment. It is important to use ointment over gels and creams because those products can have additional additives that cause further irritation, which we want to avoid. The next condition is lichen planus. So lichen planus is not common. It's present in about or less than 1% of the population. It's also important to keep in mind that about a third of these patients have autoimmune disorders as well. And with vulvar lichen planus, 70% of those patients will also have oral lesions. So if you're suspecting vulvar LP, you definitely want to check your patient's mouth. Lichen planus can also cause skin lesions as well, so you'll want to check your patient's skin. Things to keep in mind for symptoms, these patients often present with itching, burning, dyspareunia, so pain with sex, discomfort, and just kind of like a soreness. Because this condition is scarring, on physical exam you may see complete obliteration of the normal vulvar architecture. So you may see clitoral phimosis, where that skin is really difficult to pull apart. The skin is probably going to be really thin. You may have friable lesions that bleed easily. And then you can also have vaginal stenosis as well, where the vaginal canal begins to kind of narrow out. And so one thing that is important in both lichen planus and lichen sclerosus, because of this scarring nature, is to consider prescribing a vaginal dilator. Dilators can alleviate some of the scarring and sclerosis that has already happened and then prevent more stenosis from occurring. So other things to keep in mind for lichen planus: on physical exam, you may see the white reticular lacy Wickham striae. You may also see the lichen planus P's. So I don't know if you remember those from first and second year, but that's the poorly demarcated purple, pink plaques and papules. So you may see that. You may also see kind of a whited out picture that resembles lichen sclerosus, so it's important to differentiate between those two. Other P's to keep in mind: you may have elevated pH up to 5 or 6, and then this condition can also be confused with bullous pemphigoid and pemphigus vulgaris, sorry. So if you're concerned about those conditions, you may want to get dermatology on board. As far as treatment goes, we already talked about the vaginal dilator and then obviously your topical corticosteroid ointment. Moving on, last but not least, lichen sclerosus. This is the one that you really don't want to miss because it does increase your patient's chances of getting vulvar squamous cell carcinoma by 2 to 5%. It presents in a bimodal age distribution, so it's more common in prepubertal girls and postmenopausal women. And it's in the postmenopausal women that you really want to make sure that you're doing a biopsy to rule out squamous cell carcinoma. This condition is typically asymptomatic. If symptoms are present, they're going to be similar to lichen planus because of the scarring nature of this condition. Your physical exam, like I already said, you're going to see some obliteration of that normal vulvar architecture. You can have clitoral phimosis, stenosis of the vaginal canal, and then the lichen sclerosus lesion itself is often described as a white kind of tissue paper-like lesion, so the skin is very thin, and it often presents in a figure of 8 or hourglass shape, so around the vulva and then perianal as well. And again, for treatment, we talked about vaginal dilation, the topical corticosteroid ointment, and then for resistant cases, you can use tacrolimus or methotrexate, but at that point, you'd probably want to consult a vulvar specialist and get them involved as well. So I think that's about it. So we have lichen simplex chronicus, which is often a topical dermatitis, contact dermatitis picture. Then lichen planus, which is associated with autoimmune disorders, can have oral and skin lesions as well that you don't want to miss. And then your lichen sclerosus, which you're going to want to do a biopsy of and make sure that you don't miss squamous cell carcinoma. So if you have any questions, let me know. And if I said anything wrong, Dr. McGraw, please correct me and I'll pass it on. Thanks, guys.